There are a lot of immunotherapies being evaluated in AML, MDS, ALL. It's actually quite interesting, and we say history repeats itself, and that's kind of what we're seeing is that in solid tumors, the same way we had the advent of targeted therapies, RAF inhibitors, MEK inhibitors, BTK inhibitors, etc., and then there was a huge run of immunotherapies that then basically became the cornerstone of treatment. And I would say similar is emerging in AML, where we have had a FLT3, IDH, venetoclax, BCL2 that have already shown clear efficacy, safety, approved, and are being used quite frequently. In addition to this, now we are seeing that there's an emergence of a number of immunotherapies in the AML, and a lot of these are still in early phase 1-2 trials, but are showing a lot of promise. I like to think of these in 4 different buckets, although there is a lot of overlap in the mechanisms of action. So the first one is T-cell enhancing immunotherapies, and this includes your immune checkpoints that we're aware of that target PD-1, CTLA-4, enhance or remove exhaustion from the T cells, allowing them to kill tumors. There's some early encouraging data, but this is a field that will need a few more years of work, I think, before it can find the appropriate exact niche in AML. There will be data presented at EHA and ASCO this year from a number of different immune checkpoints, nivolumab, pembrolizumab, durvalumab, that have been used in different AML settings. The second is a group of drugs called macrophage-enhancing agents or macrophage checkpoint activators. This is the CD47, and the combination of azacitidine CD47 is showing very encouraging early activity in frontline MDS, frontline AML. It was presented at ASH this year and will be updated at ASCO and EHA with a focus on the frontline high-risk MDS patients, which is the registration arm of the study now, with a good number of patients, above 60, 70 patients, continuing to show high overall response rate, greater than 85%. And we're waiting to see the survival output. And also in TP53 AML, where it's showing very high activity in the frontline setting, small numbers, but we should have more data by ASCO and EHA. The third is a group of treatments called bispecific antibodies. So these are cells that have 2 different receptors, one that engages the T cells, the other that engages specific antigens of choice. And one of the bispecifics, not in AML, but in ALL, blinatumomab, has been approved for relapsed B-cell ALL as well as for MRD positive B-cell ALL. And in AML, we're evaluating a number of such bispecifics. Some of these are drugs such as flotetuzumab, which is a CD3, CD123 bispecific, the one that is most advanced in clinical trial development, showing some specific encouraging activity in the primary refractory AML, a very difficult group. There are others such as AMG 330, AMG 427, XMAB. So we do think that there may be a role for these, especially in low burden disease, primary refractory, maybe based on the flotetuzumab data, and in MRD setting. Some of the issues with the bispecifics are that they do cause CRS, usually a grade 2 or manageable one, but this is something that does require a degree of expertise with awareness, management, and close monitoring for CRS. And then the last group is the one that is probably the most exciting per se, based on everything that's happening everywhere else, which is the CAR T cells, but is also the one that is the most early in AML development. And there have been very limited CAR T cell data. There is a Mustang Bio CD123 CAR T that was presented at ASH about a year and a half ago that showed some signal of activity in both BPDCN, which is very similar to AML in CD123 expression, as well as in AML. And there are a couple of off-the-shelf CAR T cells, but at this time, really no clear clinical data as to the efficacy of these agents. But hopefully by the end of this year and early next year, we will start having more patients on these and understanding them better. So a lot of work going, and these are not mutually exclusive. There are trials that are combining bispecifics with PD-1 with the macrophage checkpoint, CTLA-4 with PD-1, CAR T cells potentially with PD-1 to remove exhaustion. And so I think you will see these immunotherapies being combined, and hopefully this will lead to some major breakthroughs and approvals in the next 2 to 3 years to add to the already approved and effective targeted therapies in AML.